Thank you. I'm delighted to be here. The last time I participated in this meeting was in 2006 when we were also celebrating Vaccination Week in the Americas that year. So it's a pleasure to be back. I look forward to this conference. You really do a great job with the organization and the quality of the work and presentations. I'm going to take a little tact, a different tact, and I'm going to tell you a story. So you just had a wonderful lunch. Kick back, let it digest, and I hope you enjoy. One of the things I hope that you recognize throughout my talk is the amazing collaboration and support that we've received over the years from the Centers for Disease Control and Prevention. So many of the things I mentioned, whether it be Rubella elimination or Vaccination Week in the Americas, if I don't mention CDC, it's clear they've been a wonderful partner, and we value that partnership going forward in the future. And what I'm going to focus on, I've been asked to talk about adult immunization, but I'm going to do so looking through the lens of the Pan American Health Organization, particularly from the perspective of a developing country. After listening to Dr. Atkinson's talk, our PAHO team loaded up and we drove off to a clinic not too far from here, actually, a Maricopa County vaccine clinic, and we spent some time there talking to the staff and observing the work, and we actually had the opportunity to take some pictures. So we want to share, as we do with many activities, share your achievements and accomplishments that you're doing here in Arizona with other countries of the hemisphere. So I thought I'd mention that. Now, this first slide covers a lot of what challenges us at the Pan American Health Organization in supporting countries. And perhaps the biggest challenge is to make accessible, to make equitable access to new vaccines. And this is a back of the envelope sort of calculation over time, the number of vaccines that are introduced into the United States, for example, represented by the blue industrialized countries, and the other countries, developing countries of Latin America and the Caribbean in yellow. And you see that time lag. And in industry, private sector, it's often said that time equals money. Well, in public health, I hope we note and are committed to time equals more people dying. So the length of this time lag equates to more children dying. And that's sort of the perspective that we take when we're working to reduce that gap. And I'll come back to this. My talk is going to cover 5 topic areas. I'd like to review what's being done this week, so you here in Phoenix, Arizona, have an opportunity to understand and learn about what's being done, for example, in Brazil or in Bolivia. I'd like to also address new vaccines, because new vaccines, whether they're for children or adults, we have some challenges, and I would like to highlight our approaches to those challenges. Then I'll end by sort of covering a few points about influenza, pneumo, and rubella vaccines in particular, and the approaches to controlling those diseases. I've had the opportunity to work in 3 different regions of the world, and what I really appreciate about the region of the Americas is this appreciation and engagement with prevention. This culture of prevention that over the years has been nurtured. It's quite different than other regions of the world because it's really supported by a very high level commitment. And so when we talk about cost of intervention, when we talk about how we are actually underestimating the value of vaccines, there's an understanding here, I think, more than other regions of the world. Also to note that my first overseas assignment in the mid-60s I was in Malawi, Africa. 1986 was the year of immunization. This was sort of halfway between the Universal Childhood Immunization Program being spearheaded by UNICEF and WHO. And there was a bolus of resources that came into Malawi, and the healthcare workers, I saw a bolus of enthusiasm, of commitment to organizing and developing microplans and strategies to prevent these diseases that they were seeing every day, that they were treating and trying to prevent deaths every day. And I decided at that time, I want that. I want to capture that enthusiasm and commitment. And so I've been very fortunate to have worked in immunization. But my point is that at some level, many of you working at the point of service in the field understand the value of prevention and the power of vaccines long before the sophisticated studies come out to show, a fully vaccinated child in Kenya has a higher IQ. And at other level, convincing the politicians or higher level takes a lot more work. But it's really to the credit of your hard work that eventually that does happen. Now, in the next series of slides, I'm going to cover that first topic I mentioned, Vaccination Week in the Americas, and also recognize the work the United States did in starting National Infant Immunization Week several years ago. But with the Vaccination Week in the Americas in 2001, 2002, if my memory serves me correctly, there was an outbreak of measles in the northern Andean countries. 2002, that outbreak was stopped because that's our last endemic case of measles. But the ministers of health of the Andean region were quite concerned that given the huge challenge to stopping this outbreak, how could they get the rest of the Andean countries, Peru and Ecuador, the outbreak was in Venezuela and Colombia, to ensure it didn't happen to them. And they started this campaign with the focus being on preventing spread of measles due to the challenge of importations. And then the following year, it then became a regional activity. So it's been, of the 9 that we've had so far, I've been fortunate to have participated in 8 of them. We have general objectives to promote equity and access in vaccination, to promote that transition from childhood to family immunization. This is going to address some of the things I'm going to be saying about adult immunization, and to promote communication and cooperation among countries, across borders, and to maintain vaccination very, very high on the political agenda. And you see how we do that and promote advocacy. This sort of summarizes the work. You see in the boxes the dates of when other regions in the world joined this activity. The text closest to the timeline highlights certain events. For example, you note the outbreak in Venezuela and Colombia, followed by the follow-up campaigns and other work in 2005. Each year we try to focus on a different theme. And in 2005, you can see we focused on indigenous populations, the family immunization, transitioning to a family from a childhood immunization program was the theme in 2006, and so on. You see that. We'll come back to the participation of the other regions of the world, because it is noteworthy and quite exciting to see that that the other regions in the world are joining these activities. Started in the U.S. with National Immunization Week, and then subsequently the movement that began in the northern Andean region for Vaccination Week in the Americas. This lumps all the data together over the years to show that in these 9 years we've been able to vaccinate more than 324 million people, most likely that would not have been vaccinated otherwise. And you see that it's across all age groups. You see those greater than 60 years of age. This is largely due to the efforts of Brazil targeting the elderly population every year with seasonal influenza vaccine. On some years, they vaccinate nearly 18 million elderly in Brazil. We'll get back to that. And the intervention of vaccination has been integrated with other interventions to make the activity more cost effective, and depending on the local circumstances, the local priorities, but vitamin A, oral rehydration salts, deworming treatments, and you see the examples of other interventions, including the way the activity is structured and structuring it so that it's a celebration, a health fair, where families come out and celebrate health, vaccinate their children, and receive other benefits of the activity. It's clearly a regional program. We've been able to, though, to target and highlight certain activities along border areas that traditionally have been very difficult to provide healthcare services. And you see examples of some of the activities there. This would be along borders. It's pulled in the highest level political commitment last year, in 2009, the president of Paraguay. You see the president of Panama on the top right with our director, president of Nicaragua, and others. So very high level commitment. We now have the First Lady of Panama today doing similar things in her country. And again, partnership. It can't be done alone, no one government, no one agency. It is all about partnership, and then taking the partnership down to the lowest community level. And if you're interested in other and more information about this, we have a website, but I show this to highlight we're using every form of communication available, whether it be the traditional newspaper, radio, TV, or website, or the newer social mechanisms of web communication as highlighted in this example. You see our director on the top left. Dr. Chan this year came on board and produced a number of sound bites to be used around the world in the other regions and the other regional directors. So unprecedented WHO commitment to this year's activity. The theme this year is vaccinate your family, protect your community. The goal will be 41 million people throughout the hemisphere. Many countries are doing their best to integrate this with other interventions that I mentioned. And some countries, for example, some of the Caribbean countries, use the opportunity, and their strategy is more advocacy. Rather than getting out and actually vaccinating, they may feel that given their local situation, that advocacy is the best way forward. So it's meant to be very flexible. It's meant to be in alignment with the nation's priorities. Here's a list of activities that are probably bigger in terms of political commitment and participation. For example, a president or minister of health. Our director was recently in Peru and Bolivia there, highlighting the importance of peoples living in the Altiplano, in the high Andean mountain region areas, and the health challenges that exist with serving those underserved populations. And she will also be traveling to the Amazon of Brazil. There the theme will be to highlight the need to improve healthcare services to indigenous populations. And you see other examples today, this week. Yesterday we were in Tucson celebrating National Infant Immunization Week, as well as Vaccination Week in the Americas, which PAHO is focused on. I also want to note, not listed in this slide, that getting back to adult immunization, El Salvador and Paraguay are using this opportunity to introduce 23-valent polysaccharide pneumococcal vaccine. Paraguay in 2006 used the opportunity to launch, I think it was 2006, to launch their Rubella mass vaccination campaign to eradicate rubella. We'll get back to rubella in subsequent slides, but again, it's depending on the local situation, the local priorities, you can see the flexibility to get things done, whether you feel the gap in your country is adult influenza, seasonal influenza, or eradicating a disease. You can see how you can take advantage of this opportunity with all the communication messages, with all the commitment and advocacy and work at the ground level going forward. Summarizes the involvement of the other regions. 5 of the 6 WHO regions participated in this year, a total of 180 countries. Next year, Southeast Asia region I'm quite familiar with because I spent 7 years there working on the polio initiative. They'll be coming on board next year, and they've actually sent representatives to PAHO and who are currently traveling throughout the Americas to observe and learn from the activities that are being conducted this week. And they'll go back next year, and I'm sure it will evolve into a global immunization week. I have a hidden agenda that would help promote the leadership of the United States and PAHO and other key partners in this region that help it get it going to take the global role in sustaining this activity well into the future. So, remember the slide at the beginning, perhaps our biggest challenge in reducing this gap to ensuring equity and access to these new life-saving vaccines. And so what I'd like to do is spend a little bit of time, not necessarily talking about adult immunization, but talking about adult immunization in the context that this is a new activity requiring new vaccines in this group of people in many countries. And so it's the same challenge of introducing a new vaccine into the childhood program. And what we try to do in PAHO is we can't do everything. So we're focused on 2 broad areas of work. One is to accelerate the policy development process. Because if you don't have policy or no one's thinking of it, it's not on anybody's list of priorities or radar to do something, then obviously you're never going to move forward. So that. And the decision may not be to introduce the vaccine. For example, in Chile, they have a great diarrheal prevention program. Their mortality among children, and as you know, pneumonia and diarrhea are the biggest killers of children in developing countries. But Chile, for excellent reasons, based on their evidence, decided not to introduce rotavirus vaccine. They had other priorities to use those resources for. But they went through the process of evaluating that decision. So accelerating the policy process, the decision-making process, once the decision is made, particularly if it's decided to introduce the vaccine, then accelerate deployment. Getting back to that original comment I made that time means more people dying. So getting the vaccine out as quickly as possible once the decision is made. Now, for policy, there's various mechanisms. I think in the Americas, we're very fortunate to have a very strong directing council. This is a governing body of the Pan American Health Organization. The United States is a member, Canada, every country up and down the hemisphere is a member. And the organization, established in 1902, is to serve the member countries. It's not our program, it's not our immunization, it's your immunization program. And obviously, because you have such great support for the Centers of Disease Control and other organizations, the US and Canada don't need the kind of technical support that other countries, so our focus is really south of the border. But we are very fortunate to have this strong mechanism, the Directing Council, where every year all the ministers of health meet to discuss their priorities, particularly from a regional perspective. But to meet and review progress in addressing those priorities. I think that 2006, the Directing Council resolution, I feel was a landmark resolution in addressing some of the policy issues for new vaccines. And basically, in summary, this resolution was a call for action for countries to expand their fiscal space to introduce new vaccines. Let's not take from malaria or TB or HIV to add a new vaccine. Let's think of creative ways of expanding our fiscal space. And they prioritize the diseases that are vaccine preventable that they would like to see more support for. And they align those with global initiatives. The one that comes to mind most frequently is the Millennium Development Goals to achieve the mortality reduction for the childhood mortality reduction target. We're finding that developing countries will need to introduce rotavirus and pneumococcal disease. It won't get them completely there because there's a lot of disease burden associated with perinatal birthing period. So, but it's critical that these issues be addressed. And then we're also fortunate in the Americas to have the revolving fund, which basically negotiates and on behalf of countries prices that are affordable, that allow for access of these new products, also benefiting the manufacturers who produce them so they can stay on the playing field well into the future providing these products. So I'm going to talk a little bit about what specifically we do with accelerating the policy process at PAHO. I'm going to refer to this initiative that we call PROVAC. It does not stand for pro-vaccine. It stands for Promoting Vaccine Evidence-Based Decisions. It's funded by the Bill and Melinda Gates Foundation. We were fortunate to receive a grant of over $5 million a few years ago for 5 years to help countries. So really the mission is to enhance national capacity to make evidence-based decisions for new vaccine introduction. And we provide the technical cooperation ensuring that all the factors that would lead to a sound evidence-based decision are there in a decision package. So whoever's making, whether it be the ACIP equivalent of a country, which we call National Immunization Technical Advisory Groups, you'll hear this term NIITAGs, or if it's some other body in the country, that they have all the evidence. This slide highlights the one aspect of the economic evidence, because we're finding over the years that that's the request most countries put to us. What is the value of our money? What's the cost effectiveness of this intervention, particularly in comparison to either the status quo or other interventions? But there's also an affordability aspect. Is it affordable? Does it meet our national budget? So the two are important to address. But the key, I think, request that we're getting for countries is to help them sort through these economic issues. And one way we do this is with the cost effectiveness studies. Now, before we started this work, there were a lot of studies from academic institutions in particular that are very sophisticated, using very complex modeling techniques and methodologies for analysis that are not necessarily practical for developing the government of a national program in a developing country. And so what we wanted to do was translate those tools for use in an individual country, still grounded in science, but was more practical. And we were able to bring in some of the best experts in the world, given their subject matter expertise for those priority vaccines I mentioned, rotavirus, pneumo, influenza, and HPV vaccines. So for example, HPV, who could you better ask for support than Sue Goldie of Harvard, with all the years of experience that she and her team have had? For influenza, Martin Meltzer of CDC. For rotavirus, Rick Reindans at the time from Emory. And it wasn't just individuals, it was a group of individuals, working groups, that then worked on transforming these more academic, sophisticated tools into more practical tools that a national immunization program could use for their policy groups. And it's been an amazing process. It's been an amazing process that has led to a number of regional workshops. We now have financial support to continue the current work. We're now thinking about what phase 2 plan of work would be. For example, dengue. We may soon have a dengue vaccine. Well, countries are going to struggle with this vaccine introduction as they did with pneumo. And we can position ourselves to help them answer those tough questions. There'll be second generation vaccines. We're currently working on the available HPV vaccines, but it looks very probable that there'll be second generation vaccines that have more genotypes that will provide broader coverage and at some cost. And so the question a Minister of Finance or a Minister of Health must ask, well, is the cost really worth the budget implications? Is the bang worth the buck? And basic question. And so we hope that we can continue to help countries with that. But we do, with the focus on national data, the national situation, the national group of priorities, which is, by the way, a real shift from the traditional approach. Traditionally, when vaccines were pennies a dose, we could go out and say, let's eradicate polio. Okay, now let's go after measles, let's go after rubella. And that was more of a regional process, certainly grounded in with the directing council I mentioned, and certainly grounded in evidence, as Alan Hinman and Beryl Irons were able to demonstrate in the Caribbean. If you invest $1 for the eradication of congenital rubella syndrome, you'll save $13 in treatment costs. And that's a no-brainer for a minister. So, but my point is that we're shifting from this sort of regional oversight, still needed, but trying to balance it with much stronger national decision process and capacity. Because we're finding once that capacity is there, it spills over the way the programs managed, the way low-performing districts are tackled, but also the response to unusual situations, an importation, a disaster, the first urban yellow fever outbreak in 45 years in Paraguay in 2008, and so on. So it's exciting work, and we're trying to, as I mentioned, use to the extent possible those local data and priorities. We still rely on data from the United States and other developed countries. This is an example. Again, a no-brainer. The potential for reducing complications in nursing home patients, as an example. I use a few slides from the Pink Book from the CDC. I'm sure you're all aware. It's an excellent resource, particularly when we're working with countries. And given that there are a number of forces and activities, not just PROVAC, but other things like our technical advisory group, the challenge of confronting the pandemic, the lump sum of all that energy, of all that work, produces results. And you can see the rapid uptake of influenza vaccine, now over 42 countries that routinely vaccinate. The strategies may be different by country. In some countries, it may be just the elderly. In others, it's high-risk groups. But there are clear recommendations, and based on the local budget, there may be some variance. But they've introduced this important vaccine. Some 18 countries have introduced pneumococcal vaccine. Some 16 countries rotavirus vaccine. I know of 5 countries that have introduced the more expensive HPV vaccine. And so all this work, I think, is helping reduce that gap that I mentioned. I think at PAHO, we're proud to be able to say that Nicaragua was the first developing country, and it's a Gavi country, to introduce rotavirus vaccine in the world, and it was only 1 year after the U.S. had done it. So a lot of effort going into this. So I'm going to shift gears now and finish my talk saying a few things about influenza and the pneumococcal vaccine work we're doing, and finally the case study briefly of rubella eradication. So Brazil is a huge country. They focused on their most populated areas, as you see in red, for their seasonal immunization, influenza campaign, and the green being basically the Amazon basin. They produced data that demonstrates coverage by district, which I think is laudable. It's a challenge to follow coverage of the elderly population in developing countries with a new vaccine like seasonal influenza vaccine, but they do have data. It may not always be the best data imaginable, but it's there and they can monitor. They've also been able to follow by age group coverage, and so using this information improve their strategy going forward. I feel like I'm preaching to the choir, and you're going to receive more information from Bill and Melinda in subsequent lectures. But just to note, I mean, virtually every country in America recognizes the burden of disease in these next few slides. Here in the U.S., second most common cause of vaccine-preventable death, and you know the syndromes that lead to death. What I wanted to note here is that complications such as secondary bacterial infection is well recognized, something that's a high priority in developing countries, particularly with influenza and measles, and that the higher case fatality rate is also noted. And you're, again, well aware of the disease burden. But in working with adults, it's important, and I say, well, we're involved in a family immunization program. Is it real? In many countries, the quality of that program may differ. It may be that it's called a family immunization program, but we still have one group focused on the elderly or adults and another group more focused on children. So it's work in progress, and it varies by country. But what's important, and I think I wanted to mention using this slide, is that everybody knows the value of the work being done with children to benefit the elderly and vice versa. That's the point. And you see the herd effect that Dr. Atkinson mentioned using other data, and certainly this noted here in this slide. Missed opportunities. I recall back in the early 90s, to eradicate polio, this was one of our key strategies to ensure that every community had high polio coverage. We conducted a series of missed opportunity studies across the region. We had protocols at our yearly tags. We actually required countries not only to present their AFP, their acute flaccid paralysis surveillance data, and other data, but to show that they were doing missed opportunity studies, and that eventually was integrated in sort of a management style that when you make a site visit to a clinic as a supervisor, you're actually looking for potential missed opportunities, looking for opportunities to improve services. Just to note in these data from the U.S. That those elderly that present with severe disease were hospitalized a few years earlier and had not been vaccinated. And it can be done simultaneously. So I'm going to wrap up my presentation with 3 or 4 slides covering rubella eradication. Now, rubella eradication, if I want to take the risk of oversimplification, the strategies are quite similar to polio and measles. And the guiding principles are really to reduce the pool of susceptibles as rapidly as possible to interrupt transmission of rubella virus. Now, the tactics to reduce that pool of susceptibles include routine, very high as possible coverage of routine, and then a campaign approach. Now, those strategies are coupled with excellence, high quality surveillance. And that basically is an oversimplification, but you get the idea that with rubella, that was the approach taken. And what I'd like to show in this slide is coverage using data from 97 to 2006 by country, and just recognizing that the campaign targets, it may differ or vary by a small amount from country to country, but generally we recognize everyone below 48 years of age. Everybody in the country below 48 years of age. That's about half the nation's population. Half the nation's population. The lower limit, whether it's all children at 12 months, or maybe in some countries it may be 2 years, 4 years, 5 years, that decision is based on when they had their last campaign, their follow-up campaign targeting children. So the lower limit may vary a little bit more. But you get the basic message. The strategy is really targeting about half the population, both males and females. You see the last 2 bars, Chile and Brazil, in yellow. They were countries that targeted only females, so all women less than 48 years of age. And what do you think happened? Did they stop transmission? No. And why? They left the pool of susceptibles, the men. The virus kept circulating. So viral transmission continued, and they, although had a lower disease burden, they still had cases of congenital rubella syndrome. So they had to go back, spend more money to redo their campaign to get them in. But there's a key lesson learned. And the point is, it can be done because all these countries, with the exception of the 2 in yellow, interrupted transmission with one campaign. One campaign. That's what I find so fascinating, because polio, you need repeated campaigns, you're knocking your head against the wall, doing these polio mop-ups and national immunization days, and it takes a few years, and in some cases it hasn't been done, but with rubella, if you do high quality, one campaign, you can stop. And the reason is the herd immunity is less for rubella. So if you do a decent campaign, 90, 85% coverage, the chances are you're going to achieve your target. So an amazing lesson learned from this activity. And here are the results. You see with measles in blue, that was a target for 2000. I mentioned the last endemic case was 2002, to use the combined MR vaccine, because that really had an impact on our subsequent challenges to eliminate rubella. It was a benefit that, in hindsight, was tremendous benefit. And so when we work with other regions, when we consult with our colleagues in WHO, we really try to make this point that if you're going to embark on a global measles eradication program, please include rubella in that vaccine, MR vaccine, in your campaigns. And we're challenged to, because we need support, and sometimes there are critics, but we're challenged to demonstrate we're doing more with the money provided, whether it be primary health care, women's health care. What I want to point out in this slide, with the help of Lou Cooper, former president of the American Academy of Pediatrics, and who, by the way, when he was in New York City in the 60s and there was a huge outbreak of congenital rubella syndrome, he was one of the key investigators to define the epidemiology of congenital rubella syndrome, and has been a backer and a supporter of our effort, and helped us in this situation in Costa Rica. In the United States, newborn hearing screening of every baby born in a hospital, the standard of care is to do the screening, because rubella virus is not the only cause of diminished hearing. There are other causes. So the benefit of this program, I think, has led to identifying other and tackling other causes of hearing loss, and that standard of care is now being translated into countries of Latin America and the Caribbean. This example of Costa Rica, some 4 or 5 years ago. I can't see the date. It's 2007, and other opportunities to demonstrate other benefits such as women's health care as well. This slide, I think, it speaks a million. What the commitment countries have. Many of these countries have vaccine laws. They believe in the power of vaccines. They believe it's a public good that should be provided for everybody in their country. And so with that background, with the culture of prevention, with vaccine laws supporting the efforts, this summarizes the financing. In red, you see the national sources of vaccine financing, and in sort of blue-green, you see external resources. And this is a challenge for promoting adult immunization, for promoting new vaccines in the adult, whether it be adult or for children. But you see, they are tackling that challenge. We hope that we're making progress with this transition that will allow us to be better positioned to serve adult vaccination services and protecting adults and the elderly. And I'll stop there. I want to thank the organizers for inviting us to be here. Thank you.